Welcome to the Northeast Georgia Health System Medical Staff Educational Podcast, where our medical staff leaders discuss updates in medical literature and practice-changing articles, while not taking themselves too seriously. We're glad you're here.
All right. Hi, guys. Welcome to our latest edition of our Northeast Georgia Medical Center Medical Staff Podcast. We are excited to have some of our emergency department physicians here with us today with Dr. Shah and Dr. West. We're a little bit light on the hosting side, and Dr. Morgan's laid up on us.
We reached 2,000 views. I think he gave up. He quit. I don't know what's happening.
Yeah, that's right. But
he'll be back next time.
He will be. So Dr. Hunter and myself, this is Dr. Dudas, just hosting our next episode here. So we've got Dr. Shah, who is a emergency room physician with us, who is also a toxicologist and actively participates in GME. So you want to say a few highlights of yourself there, Dr. Shah?
Absolutely. Well, first off, thank you for having me. And yes, I'm one of our associate program directors. I'm our director of education, and I'm dual board certified in medical toxicology as well as emergency medicine. So I love reading journal articles and keeping up to date.
Yeah, great. And next we got Dr. West, who also has been with us here for a while as an emergency room physician, and then herself as well, actively involved in the GME program. So you want to tell us a little bit about yourself, Dr. West?
Yep. Kathryn West. I am also an associate program director of the emergency medicine residency program, and thank you for having me. And I really just enjoy asking Kartik Shah what the literature says about different topics. So glad to be here today.
He's your chat GPT.
He is my chat GPT, actually.
Yeah, it's a great resource to have. Where'd you guys train?
So I actually did my residency up at Stony Brook in New York, and then I actually met Kathryn West because I did my medical toxicology fellowship at the Carolinas Medical Center in Charlotte, and that's how I ended up down here.
Gotcha.
And I did my residency at Carolinas Medical Center.
All right. And you liked each other enough to actually work together, huh?
I know, stunning, right?
Wow.
We only worked together for a year.
Kartik, I heard you got there's some nicknames for you.
The tranquil toxicologist.
Oh, yes. I am always at peace, always.
Until he goes on a rant.
Yes, at least on the outside, yes.
I love it.
Well, good. What do you guys like to do for fun? What's one thing you do for fun, Dr. West?
I keep up with my two children, my 6 and my 8-year-old children. So between gymnastics and Girl Scouts and all the other activities, I am usually pretty busy.
That's the fun time. They're out of car seats and they still like you.
Yeah, they do. That is, I am trying to enjoy every moment of it.
How about you, Dr. Shah?
Yeah, I actually do martial arts. So the one I'm currently most invested in right now is a form of Kung Fu called Wing Chun. So again, that's the tranquility.
Okay.
I'll make sure I ask nice questions.
Yeah, that's right.
Thank you.
That's right. We can add maybe some video component to this podcast somehow.
Absolutely.
Yeah. We can do all right. Well, good. Well, I think, there's two big areas we're going to jump into today. One's going to be looking at VBGs. One's going to be looking at hypertension and how we treat hypertension in the ED setting and even a component of the outpatient setting as well. So one thing that is new to this podcast, which we're excited about, this is the first time we're actually going to have CME. So took our ED physicians joining us for us to be able to get CME, but there should be a link within the notes of the podcast how you can go about doing that, as well as the references that we're going to be talking about. So with that, let's hop on in. And so the first point for discussion was an article from January 2025 in the Journal of Hospital Medicine, so a very high-quality article there.
The peak.
That's right. But talking about ABGs versus VBGs and the benefit of a VBG and kind of some different cutoffs and thresholds as to how that number can give you quick information to help guide your treatment. So just to open it up, Dr. West, when do you use the VBG and how do you typically use the information from the VBG to help you guide these patients with potentially respiratory compromise in one form or fashion?
Well, I think the title of the article really says it all, things we do for no reason. And so I think ABG often falls into that category. Sure, there's a few select situations where we want an ABG, but for the most part, in our spontaneously ventilating patients, a VBG is going to be sufficient. So if you look at the article, it shows that if you have a PCO2 of less than 45 on your VBG, then you're probably not hypercapnic. And if it's greater than 55, you probably are hypercapnic. And if you're between 45 and 55, then you're going to be in a little bit of an in-between zone. But more importantly, the pH really correlates very well on the VBG. I believe it was 0.03 difference between the VBG and an ABG pH. So if you're trying to determine if someone has respiratory acidosis, you can rely on that VBG pH.
Yeah, it looks like there's a lot of data to support that, and it's basically just becomes a math equation. It's so consistent that you just add 0.033 to your VBG, and that's your pH.
Absolutely. And the VBG, of course, we do use a lot to help make clinical decisions. It's part of our altered mental status workup, hypercapnia, but it gives us lactates. We use it in our sepsis panels, and it's a very fast point of care test, so it's a useful tool, but ABG is not benign. It hurts, it costs more money, it takes up resources, including our respiratory therapist, whereas a VBG can be, again, done with a venous sample.
Yeah. I know when I trained, it used to be like, can't trust that VBG for anything. You got to get an ABG. And that's apparently something we were doing for no reason a few years back.
And it looks like for the PvCO2 of less than 45, they list multiple studies here. It's been proven again and again that if your PvCO2 is less than 45, then you do not have hypercapnia, and those correlate very well.
Absolutely.
Yeah, I had to, brush up on my sensitivity and specificities. Just like taking the boards, had to brush up on the definitions again. But,
that's why we brought Kartik here.
Yeah.
Absolutely, I got you. Spin and snout, that'll be great.
Yeah, there you go. That's right. Yeah.
I saw there's even data that they can use it to trend. So you get that, even if you need an initial ABG, then you can follow it up with VBGs to kind of trend your PCO2 level. I thought that was surprising, and it's so much easier to get. Again, much less risk of adverse event.
Yeah, absolutely. And so often we'll get an ABG, again, in our, let's say, non-spontaneously ventilated patients, let's say when we intubate somebody, but then again, we can switch to a VBG. It's much more comfortable and easier to access unless you have an arterial line, and that's often in the ICU.
Sure.
And then other times that we think about this is even in our, let's say, bad COPDers who are baseline hypercapnic, since they are baseline, what we really care about is the pH, and that has such good correlation with the ABG that we want to make sure that their pH normalizes, not their PCO2, which may never normalize. And so, again, the pH is so good that we can still use VBGs even in our COPD patients.
Yeah. You like that pH as a toxicologist, huh?
Oh, yeah, I love it. It's it's a very helpful tool.
All right, any other comments on that?
No, I think that's a pretty quick, high value, high yield article. Again, we'll have the show notes with this listed in there. So if you want to do a deeper dive into some of this data, you can definitely do that. But
and I do think that's something that you guys probably do pretty good in ER, utilizing that, and us on the floor and even in the ICUs could probably utilize a little bit more than we typically do, just based off of the speed of getting the lab test back and the comfort and risk and that sort of thing.
Absolutely. It's a lot quicker than having to wait for a respiratory therapist to be available in order to draw an ABG.
Sure. All right. Well, now we're going to move on to hypertension.
This one's not as easy.
Yeah. We got always an area of some controversy, but we asked our ED colleagues here to send us an article as to what they wanted to talk about, and they sent us, I think it was a 116-page article. So thanks for that. Luckily, we kind of narrowed in on that some. But pretty much this article is the American Heart Association, American College of Cardiology 2025 Clinical Practice Guidelines for Hypertension Treatment in Adults, right? So this is the most up-to-date information we have for treatment of hypertension, and specifically what we're talking about here is treatment of hypertension in the ED and looking at hypertensive urgency versus emergency and that sort of thing. So I'll just kind of open it up, and the definitions I think have shifted a little bit from what we have historically called hypertensive emergency and urgency. So do you guys want to just kind of go through and comment as to how you use the definition of hypertensive emergency versus hypertensive urgency, which really isn't used anymore?
Yeah, so initially we had these older definitions, and the idea was that there is a certain blood pressure where you're at risk for immediate stroke and you're kind of going to drop down and die, and that's where it initially came from. But now we realize that patients actually, at least in the short term, can tolerate this pretty well, and in fact, if they are asymptomatic, they probably had this for a decent amount of time. And so the key differentiator is whether you have symptoms. So that was the old way of defining hypertensive urgency versus emergency, is really, do you have symptoms and any acute end organ damage?
Yeah. And the the terminology hypertensive urgency has really fallen out of favor, and now we prefer to use the term marked hypertension.
Yeah. I think the article even refers to it as marked or even sometimes just severe hypertension, which I'm sure we'll get coding inquiries if we put that down saying that we're wrong, but that's okay. So I guess looking at that definition, what do you guys consider end organ damage? That's a little bit of a unique definition as well.
Yeah, unfortunately, the guidelines actually help us out with this. So I'm actually going to read from the figure. So there is a figure 9 on page E185.
See, very, very short document, page 185.
Exactly. I mean,
everyone just flip your pages, just follow along.
And for full disclosure, I chose this article, so obviously I was thrilled with this, but I guess sometimes, it's a little long. My bad.
Treatment of asymptomatic hypertension causes Kartik Shah to have hypertension.
Symptomatic hypertension.
Yeah, I need a prescription after this, actually. So figure 9 is entitled Diagnosis and Treatment of Severe Hypertension and Hypertensive Emergency. And the systolic over 180 or diastolic over 120 is where we will start with. And then we see that the first box after that is acute target organ damage, and there's an asterisk. So at the bottom, we'll see what the AHA considers, and I generally agree, is what acute end organ damage is defined as. So they note is defined as acute heart failure or pulmonary edema, neurologic disorders, so PRESS syndrome, encephalopathy, retinal hemorrhage, papilledema, intracranial hemorrhage, acute ischemic stroke, acute decompensated heart failure, acute coronary syndrome, acute kidney injury, acute aortic syndrome, such as a penetrating aortic ulcer, aortic dissection. And I would generally agree that these are all really bad entities and will have symptoms. So that's what I would define as acute end organ damage. Some of the things that is not in this particular figure, but in a different part of this is, for example, our pregnant patients. So eclampsia is another time that I'm going to very much care about blood pressure, but that was not included in this particular figure.
Is headache considered as end organ damage for elevated blood pressure?
So I think it depends. We have to have some clinical correlation. Part of this is that blood pressure can rise simply due to pain. And so there are times that a patient may come in and they will say, I have a headache, and their blood pressure will indeed be elevated. And so I'll have to basically ask them, do you have a history of migraines? Does this feel similar to your migraine? And often they'll be like, yeah, but this one's a little bit worse. But yeah, I do get migraines, and I take my meds that I get prescribed, maybe my sumatriptan or whatever I get, and it just didn't work this time. But usually I can get helped in the emergency department. And so my first line medicine is a pain medicine. Actually, it's not labetalol or something to bring them down. It's actually pain medicine. Their headache gets better, and oftentimes, again, their blood pressure will also get better. Versus if we look at some of these syndromes that were defined, the neurologic syndrome, so posterior reversible encephalopathy syndrome, so PRESS. It's not just a headache, but it's going to be altered mental status. It's going to be visual disturbances, and so they're going to have a decreased level of consciousness, and we'll, again, see things on MRIs, for example, which, again, I don't routinely get in the emergency department, but that's how it's a headache plus something else. It's going to be someone who's not, looking at their phone right now, and be able to converse. So I'm going to use my neurologic exam quite a bit to decide whether that headache is a headache or, again, it's something a little bit more sinister.
Gotcha. What about confusion?
Again, I think confusion is very multifactorial. So hypertension is often a symptom of what's going on and not necessarily the cause. And I think our job doing a detailed history and physical exam is to figure out, well, is this confusion caused by some sympathomimetic toxidrome? Or is this confusion caused by some other kind of process that's causing hypertension as well versus hypertension causing the confusion?
Exactly. Like this hypertension, and again, often with tachycardia, is a sign of a sympathetic surge often. And so why is the body under a stress state? The same idea with hyperglycemia, right? The body is under stress for whatever reason, maybe connecting to our first article, maybe they're hypercarbic, right? And so who knows? And so we have a pathway, again, doing our history and physical and certain diagnostic tests to help decide, again, is this related? Is the hypertension primary or secondary? Is it secondary to some other reason? And then let's treat the secondary reason versus just treating the number. Let's treat the patient.
I think it's also important to note that several society guidelines also state that there's no routine indication for diagnostic studies in workup of a patient with asymptomatic hypertension. So if someone comes to the emergency department and is just because my blood pressure at home was 200 over 100, what we're going to do for that patient is just a detailed history and physical. And if we don't find any signs of an organ damage on our physical exam, so we're not finding any confusion, we're not finding any chest pain or something that would make us concerned for an aortic pathology, then we are providing a lot of reassurance and discharging home without checking any other diagnostic studies.
And this actually is in the outpatient setting as well. So actually referring to these guidelines, if we had followed this figure down, so if we go to acute target organ damage and we say no based on our history and physical, and there's severe hypertension identified in the outpatient setting, it says no need to refer to the emergency department, reinstitute and intensify or modify medical therapy in the outpatient setting, even though, again, the first part of this pathway is a systolic over 180 or a diastolic over 120, which are very scary numbers. And of course, we have to address this with our patients because, anyone is going to be terrified looking at that if they saw that at, let's say, CVS and getting their blood pressure taken. And this has actually been consistent. The 2017 guidelines from the American College of Cardiology and the American Heart Association have said this as well. So this has been going on for almost 10 years, and I'll quote those guidelines, where the same idea of looking at what they called hypertensive urgency at that point, but the same idea, there's no symptoms. This is a severe blood pressure elevation in otherwise stable patients without acute or impending change in target organ damage or dysfunction. There is no indication for referral to the emergency department, immediate reduction in blood pressure in the emergency department, or hospitalization for such patients. So it is kind of scary. It's hard to tell our community this, as well as our fellow medical professionals, because we've both had patients that say sent from a dentist's office that this occurs, and understandably, again, these are scary numbers. Vital signs are vital for a reason, but sometimes the timeline of when we need to address this is important.
Is there a top number that you would get worried about if their, systolic is 500 and their diastolic's 250?
I don't think I've ever seen someone who's truly asymptomatic above 260 over 150. Usually, if you ask the right questions, you will find that they truly are symptomatic when their diastolic gets above 140 or so. What would you say, Kartik?
Yeah, I'd say that. At a certain point, I think everyone's going to get symptoms. I think the highest I've seen that's asymptomatic is probably roughly a systolic of 260. And then once you hit like 280, 300, this is a problem. I think anyone's going to be like,
yeah.
So interestingly, I also read a study once that they looked at blood pressure during intensive strength exercising. And if you're doing squats, your blood pressure your systolic's going to go up by about 80 millimeters of mercury. So I always have this conversation with my patients where I say, hey, look, a lot of times your hypertension is just related to what's going on in your life, and that maybe this is just telling us that you have other things going on. And it's not necessarily causing your acute symptoms today. It can be a really hard conversation to have with patients, however, when they're looking online and they're seeing stroke range blood pressures. This can take a lot of time to sit down with our patients and explain to them, hey, this is why I'm not going to lower your blood pressure, because it causes more problems if I lower your blood pressure. So this morning I asked ChatGPT, hey, my blood pressure is 190 over 130. What should I do? And ChatGPT said, you need to go call 911 and go to the emergency department today. So this is what our patients are seeing. They're seeing all this information that's telling them that this is dangerous and in-organ damage. But the evidence is telling us that if we acutely lower their blood pressure, we actually cause more problems.
ChatGPT didn't ask if the patient was doing squats, though.
Yeah, that's true.
Didn't ask. Did not get a good history.
Exactly.
ChatGPT cannot perform a physical exam.
Yeah, and again, going more on data, again, we can't list every article, but to that point, they've actually done studies in the emergency department. So one was, I believe, in 2015 by Miller, and they looked at about 40, 50 patients who had severely elevated blood pressure, and the ED physicians felt compelled to lower their blood pressure, again, based on common practice. And what they found is about 5% of these patients actually had acute neurologic changes. And so just a quick discussion about the pathophysiology of this is that the brain has an autoregulatory function, right? So it will always preserve perfusion to itself. And so if a patient is kind of talking to you, has a normal neurologic exam, kind of texting on their phone, and they do have this elevated blood pressure, and then when we acutely lower it, then the brain can't autoregulate fast enough. And so in a sense, we are causing hypoperfusion to the brain, which in another word is a stroke. And so this is the danger of lowering the blood pressure too quickly when their brain is used to this. And so absolutely long-term, the data is clear. There's a mortality benefit when we get the blood pressure lowered, but that is a 1 year, a 5 year outcome. It is not supposed to be done immediately in the emergency department. And again, there's a real harm to this if we do.
So how much do you dive into, have you been checking your pressures at home? What is your blood pressure chronically? Is this a new finding?
So the vast majority of these patients actually have a known diagnosis of hypertension. If I have someone that I have no history on, that literally this is the first time they decide to check a pressure on, one of the clues that I will have towards this is EKG, which is, again, a fairly benign test, and I'll see often LVH, so that their heart has clearly had some strain for a while and has been used to this blood pressure.
Their heart's been lifting weights.
And it has, unfortunately, a little too much. And again, this is one of the times that, depending on how good outpatient follow-up they have, that our ACEP guidelines, the American College of Emergency Physicians, do note that it is an option, but again, not mandatory to start blood pressure medicines, because every medicine is actually a toxin, in a sense that we're hoping that the benefits outweigh the risks, right? So all of these medicines have side effects. I personally, for example, if I need to, would start amlodipine, because I think the ratio of cost and benefit and risk is most favorable for that versus some other ones. And the GENC guidelines actually support amlodipine as one of the first-line agents for the vast majority of people. But I believe actually on one side of the spectrum for this. I actually tell patients don't keep a diary because what happens, I find, is that patients will keep a diary of their blood pressure, and they'll see it's really high, and they'll be like, oh my God, and then they'll put into ChatGPT, and they'll be like, I'm going to die. And so then their blood pressure gets even higher, and they get more anxious, and they come back. So I tell them, Olympics are on, you should watch our gold medalist figure skaters, and so on. Get this rechecked, do it the correct way, make sure it's a correct size cuff, make sure the heart is at the level of the cuff, and so on. And if it's still high, you have someone who is going to be able to see you long term and make sure you get the right management.
Yeah. One of the interesting things that I noticed in this article was it talked about without any treatment whatsoever, your blood pressure is going to go down 40 to 50% of the time. So to your guys' point, just kind of having the external influences of life just kind of causing that blood pressure to go up, and you kind of move forward and take a deep breath, kind of calm down, then the blood pressure is probably going to come down.
I think we've covered a similar article in our journal clubs in the emergency department that everyone's blood pressure tends to regress to the mean in the emergency department. So that usually means a fall of a diastolic of about 11 millimeters of mercury when you look at all comers. And then when you look at hospitalized patients, it's not uncommon for patients to have wild swings in their blood pressure. So it might be markedly elevated. And then when you check vital signs 4 hours later, they might have dropped their systolic by 30 to 50 points. And so, you can see how if you had treated that markedly elevated hypertension initially, and then they naturally were going to have a correction of their blood pressure, you might overcorrect.
Yeah. I guess, now say you have someone with symptomatic hypertension that comes in, right? And their blood pressure is 240 over 140. I'm just making stuff up here, right? But it comes in with symptomatic hypertension. How fast do you want to bring that blood pressure down? What are kind of your goals and when you have that patient that does have some end-organ damage and an elevated blood pressure?
Yeah, absolutely. Just to piggyback off that point that Dr. West had mentioned, because I think this is also going to be a very surprising statement for many people to hear on the inpatient side, but there's a class 3, meaning there's a recommendation against the following thing because there's harm. So for adults with severe hypertension, as defined by systolic over 180 or diastolic over 120, who are hospitalized for non-cardiac conditions without evidence of acute target organ damage, intermittent use of additional IV or oral antihypertensive medicines are not recommended to acutely lower the blood pressure. Antihypertensive drug treatment should be used with extreme caution in hospitalized patients with asymptomatic severe hypertension because spontaneous falls in blood pressure without any antihypertensive agents occur commonly at a rate of 40 to 50%. Observational studies have shown that initiation or intermittent use of additional IV or oral antihypertensive medications in patients hospitalized for non-cardiac conditions are associated with increased risk of in-hospital mortality, acute kidney injury, and prolonged hospital stay. Asymptomatic patients with severe hypertension can be treated with careful and frequent monitoring using standing medications and avoiding as-needed medications. So, again, there's a real harm involved in lowering this blood pressure without symptoms. Now, going to your question, how much would we lower it if they have symptoms, I think it depends on what that acute end organ damage is. And if we go back to that AHA document, they actually separate out several of these entities. So for example, in an acute dissection, then I really want that blood pressure rapidly reduced. I want it under 120. Or if you have chromocytoma, that again has to have a systolic under 140 in the first hour.
I've always been taught for aortic dissection to titrate to hemiparesis.
Get it low. Get it low.
Can it go lower?
Exactly. But otherwise, let's say for some of these other ones, they say reduce the systolic by 25% in the first hour and to under about 160 over 100 over the next 6 hours. And then over the next few days, you can normalize it or, again, continue with that process. So I think it does depend on what is the cause of that hypertension that is causing acute end organ damage.
I think that's a good point. You don't want to drop it drastically because then you're going to fall outside your ability to auto-regulate.
Right. And they make that comment multiple times here. This is something you control over days. Again and again, they say that this is something that should be done in an outpatient setting, or if you're in the hospitalization across days, because you're going to do more harm than good if you acutely lower it and get the number that you want.
Yeah, and to your point earlier, I don't have the data to support it, but I'm guessing probably the number one page we get on the inpatient setting is, hey, patient X's blood pressure is 180 over 95. What do you want me to do? You know, it's just something that has been ingrained in our medical community. That's, oh man, high blood pressure is bad. High blood pressure is bad. We got to treat it. We got to treat it now. And that's just, this article kind of, gives you some evidence that the old dogma is old. So
I hear it might also be criteria for a rapid response on the floor, that if it reaches some arbitrary number, then you're going to get a rapid response and you're going to feel pressure to treat these patients.
Right.
That's true. And I think we're gradually changing a lot of those things. We've changed up order sets. We've removed PRN blood pressure medications. We actually have warning signs on those medications now. Hey, consider this if you're going to order something like an IV hydralazine or labetalol, that you really need to use those judiciously, because they do have so much risk of side effect now that we've evaluated this. But we still get a lot of questions from the patients too, and I feel like the patients I feel like I have a little bit easier time. Sometimes it's other staff, nurses, things like that. How do you guys educate your staff, talk to your staff about this? Because I don't think this has really trickled down through nursing guidelines, things like that quite yet, and I'm sure it will be, but we clearly have some room to go there.
Honestly, I think this is one of the most powerful tools. It's a podcast, or again, these AHA guidelines are, I think, very helpful, because the American College of Emergency Physicians had their guidelines on this actually even before the AHA. So this their first set of guidelines was in 2013. But I think it's different coming from the AHA, or the American College of Cardiology, the ACC, and we have a discussion. And again, I think the nurses and all of us really just want what's best for the patient. And so we explain what is the real risk, right? Because there's no risk and there's, this potential benefit in their minds, like we should do it. But when we explain that, there's data and there's pathophysiology that backs up that data, that we actually could harm these patients. We could cause them to have a stroke, increased length of stay, acute kidney injury, again, potential mortality, then we're like, oh yeah, what's best for the patient? And I think once we all realize that, I think just having that discussion and that education, I think really helps.
Agree. I think it's just reiterating the education.
Yeah, and I think, one of the nice things is within this article, it gives the level of evidence and kind of grades it, things like that. But, one of the things it calls out here is there's harm, right? It's a level B evidence harm. So more than expert opinion, not randomized control trials, but kind of somewhere in between, where there's good evidence to say that there's harm for adults with severe hypertension of 180 over 120 who are hospitalized for non-cardiac conditions, without any end organ damage, that if you give them antihypertensives, there's harm. And that's the last thing anyone wants to do, right? We don't go into this business to cause harm. We think we're trying to do a good thing for these patients, but reality is we're harming them. We're putting them at risk for acute kidney injury and increased length of stay and all that other stuff we talked about earlier. So, any other comments on that? Really interesting topic. I think there's a lot of chatter in the medical community about this for sure, and I think that we've got a lot of progress to make, but hopefully starting to steer the big ship in the right direction with it.
Yeah, I think just getting the word out and letting people know that there's that risk of harm, and that we usually want to educate our patients that we want to control their blood pressure in the long term, and not acutely lower their blood pressure is the most important thing.
Yeah. So last thing we'll bring up real quick, the third article that was touched on was just about treatment of patients who come to the ER with hypertension, right? Can you give them medicine? Can you not? What's the right thing to do? So I know you guys printed an article from your department with a sort of a position statement, I guess. So not great evidence behind it, but it's a position statement. It's kind of almost consensus statement about that. So thoughts on if a patient does come in with hypertension, and symptomatic versus asymptomatic, when would you treat, when would you not? Is it appropriate to put them on oral medicine and send them home with follow-up or not? Comments on that?
I absolutely do initiate antihypertensives from the emergency department in patients that I'm discharging home, but I usually like them to be in the more marked hypertensive range because maybe they're just, they sprain their ankle and they're very nervous being in the emergency department, and their systolic is 150, and maybe at baseline they're not quite as hypertensive. So I think if someone's blood pressure is consistently above 180 in the emergency department, though, you can reliably assume that they have some underlying hypertension. And it's that person that I usually do start on amlodipine simply because I feel more comfortable. I'm not sure if they're going to be able to follow up and have a recheck creatinine done in the next few weeks or something like that. And so I usually choose, and I know the cost of amlodipine is something that most of my patients can afford. So that's usually what I choose.
Yeah.
Same. I don't always do it, but I think, again, these severely elevated blood pressures and they're consistently high, I think it's very reasonable, and I think that's what the guidelines state. But if they, let's say, already have an established primary care doctor and they're able to follow up in the next week or two, I think it's also reasonable to say, hey, if you're comfortable with this as well, I think it's okay for your primary doctor to do it. But if they're really worried, and again, I would understand why, then I'm happy to write them a short script for a week or two. Again, we always adjust on the situation. The longest I've ever written is actually 6 months, and I had a man come to me that said he lost his primary care doctor, and he's starting a new job that requires him to travel every 2 weeks, and he's going to be in 6 or 8 different states over the course of the next 4 to 6 months. And he's like, to be straight, guys, amlodipine has worked for me, and I'm not going to have a doctor, and I'm just not going to be able to. And so, again, we work with our community to do what's best for them. And so I've never written a script as long as that, and that's the only time I've done it. But, again, I think we adjust to the situation. But that's how I kind of play it as well.
Yeah, there's risk benefits with everything we do, right? Everything we do is risks and benefits. So,
no, that's great. I'm proud of you. That's fantastic.
Long-term medications.
That might have to go up on a board somewhere as like a record.
Up next, he's going to be prescribing insulin.
Oh, a little sliding scale here. And, here's some finger sticks.
Cholesterol management.
Yeah, there you go.
An outpatient colonoscopy. I mean, I know the U.S. Preventive Services Task Force guidelines. Get your little AAA ultrasound after 65.
Home sleep apnea tests.
Exactly. Yeah. We are going to optimize the care for our community here, right now.
Are you sure you're not an internist?
One-stop shop.
Exactly. Yeah. It's my third board certification, actually.
Well, good. Well, here's my take-homes, and you guys please chime in. But looking at VBG versus ABG, VBG, really good test to get, right? You get it quick. Risks are pretty low. That cutoff of 45 is less than 45, probably not with hypercapnia respiratory failure. More than 55, probably with a component of hypercapnia respiratory failure. That pH, you can take that pH, add 0.03 to it, and that should be a pretty darn accurate estimate of what your ABG pH would be. When it comes to hypertension, right, almost less is more, right? And unless you're symptomatic, really don't be chasing the number, right? Treat the patient. And if the patient is asymptomatic, it's okay to go ahead and start them on some oral medications. You don't need to drop them really quick. You don't need to do anything crazy from that standpoint. And honestly, they don't need to get them into the hospital, right? It's something that is really an outpatient treatment based off this algorithm. If they are symptomatic, then that's a different story, right? We want to bring that blood pressure down, usually to about 25% within the first hour, and then bring it down to about 140 to 160 over the next 4 to 6 hours, and then kind of get them down gradually from there. So I think that this evidence here is really good. I think that the most important thing is you've got an elevated blood pressure, 180 over 120, then we don't need to freak out. And historically, as a medical community, we do. We're like, oh, we got to treat the number. If that patient's asymptomatic, it's okay. You don't need to push a bunch of IV medications. You don't need to do anything. Just kind of observe them. And as I said, 40 to 50% of the time, it's going to come down on its own, right? And then we don't need to do anything that could potentially hurt them.
Yeah.
So,
first, do no harm.
That's right.
So true.
So,
It's been a pleasure having you guys. This is a tough topic. I appreciate you diving into this one. This is definitely practice changing for many of us, and we're making progress, but we still got a lot of ways to go. And so I really appreciate you guys showing your interest in this and getting it in front of us.
Of course. Thank you for the opportunity. I know I really enjoyed this. Thank you so much.
Yeah.
Thanks for having us.
Next time we're going to ask for a 200-page article, so be ready.
Absolutely.
All right. Thank you, guys. We really appreciate it.
This podcast is accredited for continuing medical education. There is no commercial support for today's episode, and any financial relationships of our planners or speakers with commercial interest have been mitigated in accordance with the accreditation standards. To claim your CME credit for this episode, please complete the evaluation using the link located in the podcast description.